Okay, so today I am so privileged to be joined by the amazing Carol Petersen, who, quite frankly, has changed my life personally through your teachings around progesterone and also through my work. Because without having been able to hear the incredible information and experience you have around progesterone, my work just would not be able to do what it does with then passing that information on to other women. So, firstly, a massive thank you for everything that you are doing around your work with progesterone. And thank you for being here today because Carol has over 30 years' experience with bioidentical hormone therapies, have attended hundreds of medicine conferences and complementary medicine conferences, written and edited newsletters, reading, researched a staggering number of books and scientific papers, co-hosts Take Charge of Your Health Radio, and is practicing as a compounding pharmacy specialist. And in my opinion, Carol, when I talk about it, I'm like, Carol is the international lead on progesterone conversations. You know, I feel so safe with the information that you share. And I really hope that through this conversation, we can help spread more of that information. So welcome and thank you for being here.
Oh, that's beautiful. You bring a tear to my eye.
Honestly, I cannot tell you. I truly believe I'm an ADHD woman. I'm genetically predisposed to never sleep, to have raging anxiety. And because of what I've learned around progesterone and have been able to access the right amount for my body, all of that is so well managed. You know, I'm not saying it's treating it, but it's managed. And therefore, for me, that medication isn't required, which is so in alignment with my values for me personally. And I just think if we can share this information, just brilliant stuff. And I think what I'd love to get in today with the conversation with you is around a lot of the myths that are coming up around progesterone, because I longed for the day where people were talking about hormones around mental health and particularly for me, ADHD. And now I want to backtrack that because it's become everyone is talking about it, but in a way that's really misinformed. And I'm seeing misinformation spread so quickly. So before we jumped on the call, you showed me an amazing diagram that I would love for you to share, where we're talking about dosing around progesterone. So
Would
I'm
you
going to
like me to
hand
pull
over
it
to
up
you.
right now?
Yeah, perfect. Let's go.
Okay.
Let's get into it.
So can you see this okay, or
Yes.
should I but okay. So this slide, I prepared it in a talk about progesterone and breast cancer, which is another issue, but let me just get down to the bottom line. Progesterone is very protective against breast cancer, is the bottom line, and few people recognize that. But what I'm talking about all the time is this biphasic nature of progesterone. And I suspect very much that it also applies to a few other hormones like pregnenolone too, but I don't have evidence at this point. But let me back up just a minute, because my experience that few other people have had is using the hypothesis or theory of Dr. Katerina Dalton over there in the UK. So it's kind of ironic that the UK has all these problems with not enough progesterone when the brilliant woman, Dr. Dalton, um, defined the symptoms of PMS and used progesterone to overcome that. So back in the US, rather than use suppositories, the whole idea of Women's International Pharmacy, where I started working, was that we will use Dr. Dalton's generous dosing, but do oral capsules. So we did this long before the Utrogestin. Maybe Utrogestin was available in France at that time. It was not very available, and Prometrium in the US had not gotten FDA approval yet. But our experience with this, we started with generous dosing in PMS. starting dose was 100 milligrams 4 times a day with the capsules. And then for some women, this was okay. For other women, it was not enough. And so they would have higher doses, and we would ended up doing compounding all sorts of progesterone for those women, the capsules, vaginal suppositories, rectal solutions, lozenges, creams, gels, anything to get progesterone absorbed. And we would get to a place where finally that woman was comfortable, her PMS symptoms, and these were the worst of the worst. These were women who were suicidal every cycle, had intense migraines, the pain was unbearable, and progesterone was the answer. It could modify that. Years later, I started wondering why so much progesterone was needed for those particular patients. And you have to consider each person's physiology, biochemistry as being unique. It's not a one size fits all in this. So I was quite comfortable with very generous dosing of progesterone. And it's so important that you look for the clinical results. I have on my website a blog on progesterone deficiency symptoms, and I took it, actually, I referenced it from a woman named Ray who she compiled these because of her own situation with problems with not enough progesterone. So there's like 125 symptoms of low progesterone that women aren't even aware of, that this is related to their hormones. Conventional medicine fails to look at hormone testing, fails to understand some of the relationships with what happens to your hormones. And so I'm 30 years past this original work, and it still holds true. What happened about that time was John Lee wrote a great book on progesterone. He truly did. However, he was very short-sighted in that he said women only make milligrams of progesterone, and they don't need any more than that. So it has a lot of fallacy, and he created some problems. He promoted a product called Progest at the time, and it had 16 milligrams of progesterone per dose. And we weren't selling that product at Women's International, but Dr. Julian Whitaker had a newsletter. He brought out that Women's International had the product, and we were compounding with bioidentical hormones. So we got so many calls. We had to get the product. And then we also got the phone calls afterwards, this small dose of progesterone making women worse. Of course, we had no problem with that. We understood what they needed. They needed more progesterone because we were compounding this all the time. And we knew from having a woman be pretty comfortable during one particular menstrual cycle, another time she might need a little more. And we would call it estrogen breakthrough, actually, that she needed a bit more progesterone. And that's where we were doing lozenges, because you get a quick absorption of progesterone to get you back to comfort. And so I heard John Lee speak at a conference sometime later, and he addressed this. He also had a lot of women complaining about that product, Progest. And he said, oh, just keep using it. In 9 months, you'll be fine. Maybe that's true. I don't know.
Who wants to wait the 9 months, though?
Who would tolerate that? And we knew from our estrogen breakthrough kind of situation, we knew we could change that within an hour or two. Why would you do that? And so that very low dose, as you see on the slide, puts you in a situation where things are turned on, magnified by the existence of progesterone. But if you come into this situation with a long-term deficiency, you're going to set up all kinds of problems. And women have gone to the emergency room even with a small dose of progesterone. Why would that be? One of the things, I think it's also involved in adrenaline getting a bit magnified, because they can get heart palpitations, which
Mm.
is when your heart is beating out of your chest unrelenting. What are you going to do? You're going to go to the hospital.
Yeah.
And you're going to know cause and effect that progesterone caused it. And so that poor uninformed woman has been given the wrong dose, and she also now knows for a fact she can't take progesterone, because she tried it before and it was horrible, the most horrible experience. Everything that she was suffering from was magnified. And I think it's receptors get lit up or whatever. I don't think enough research has been done on that end. But then I know from my early experience, thanks to Dr. Katarina Dalton, when you start at a dose at least 400 milligrams per day during the luteal phase, most of the time you don't have any of that. And in fact, if you do have any, just boost up the progesterone right away and you have no issues. At the time, once I added up all the milligrams one woman was taking, she was like 2,500. And it wasn't all the oral capsules she was
Yeah,
using.
I feel, and that is probably something that people watching this might resonate with, is they've had an adverse reaction, usually to too low a dose, which is what is standard and available, and have been told, that's it, you're progesterone intolerant, you can't touch that. Or they've had an adverse reaction to a synthetic progestin and been told, you're progesterone intolerant. What would you say to the women who have gone down a route that would be considered much higher than that? So maybe 1,000 mg in a 24-hour period. And yet they're still having these negative mood where sometimes it can go as far as suicidal ideation. What do you usually see is happening there?
What and they don't have enough. Early in my career, I had a woman. I'm working in Wisconsin, and she's in California, and she calls and she wants to kill herself, and she had just been prescribed progesterone, 100 milligrams twice a day, luteal phase only. I said, take your progesterone and use it every 15 minutes, and we'll see if this can flip. And I said, we'll talk in 1 to 2 hours. So we reconnected. She's fine now. She's that fast. And
Amazing.
she said, this just proves what I think. She said, I know it's my hormones. And she said, the doctors just want to put me on Prozac, and I don't want that. And so then I get a call from the practitioner who prescribed that to her, um, kind of complaining to me that I dared to give her different dosage instructions. I said, would you rather she be dead? And
Yeah.
just
Yeah.
from suicide, it can be this much. And so I know that particular patient said she was not going back there, but I hope, I really don't know. But now she knew, and she felt for herself the calmness that progesterone can give you. And that's absolutely a good sign. If the dose of progesterone makes you more anxious, you don't have enough. I'd
Mm.
also like to say that when you are suffering, and this kind of comes up more toward perimenopause, there's a lot of new diagnosis with ADHD. At perimenopause never was an issue before. Why would that be? Because you become more and more deplete in
Yes.
progesterone. Progesterone, consistent with perimenopause, is missed ovulations, and it's tricky because you still bleed,
Mm.
and you may have not ovulated, so that big old surge of progesterone that's supposed to be happening in the luteal phase flatlines, and
And
you
let's
you
just set this up. So this is what Carol's talking about, is this is a real, much more accurate image of the levels of progesterone. So we're always producing the progesterone, but when we're ovulating, we have a massive surge of it that comes through here. Now, what we see in perimenopause is months where we're not ovulating, and also where this progesterone declines. And this is something that I feel so passionate about, Carol. So thank you for saying that. Is like everything in the ADHD community, there's this obsession with estrogen. The small number of studies that we have, it's like, oh, it's estrogen withdrawal. And so the study that I did on perimenopause and ADHD absolutely showed this. Of course, perimenopause is a time where the lid comes off of our traits because progesterone declines, the mood stabilizer, the nervous system support, that's what goes. Estrogen's fine for years,
Yep.
is what I see on test data. They don't need estrogen. It's the progesterone coming off. So no wonder the lid comes off, right?
Oh, and it's even worse than that. Dr. Jerry Lynn Pryor from the University of British Columbia was able to demonstrate that women have the highest estrogen in their whole lifespan during the perimenopausal years. So that the difference between estrogen being quite high, although it can be a little wobbly, and progesterone becoming more and more deficient, this extreme dichotomy worsens. So that's when symptoms really start coming, and it's so obvious because you can track ovulation, you can see it's not happening, you can track the symptoms, and progesterone is the answer. You know that clinically, except we have muddied our understanding. I'd like to just say hot flashes and vasomotor things because we've gotten it in our head. And why? And it was probably because Premarin, the estrogen from horses, was first approved by the FDA for vasomotor issues. Um, and I think it's kind of messy. We use that, but Premarin it's got estrogens, it's got progesterone like substances, and it also has testosterone like substances. So when you're talking about estrogen, we kind of muddy the field too with Premarin, which is a whole bunch of hormones, with maybe just estradiol by itself, which is our major ovarian hormone. When we're having studies, sometimes we're mixing those two things up too, just as you mentioned earlier. In the medical literature, they often are not clear about the distinction between progesterone, the actual molecule your body makes, and all the altered ones, which we award companies for making alterations. And one of the first arguments was that progesterone was so poorly orally absorbed that we need to make alterations so we can absorb it better. But the fact is, and actually, this was Hargrove and Maxon with the capsules, it is very well absorbed. It's absorbed like a fat. Um, and we also have this idea that when you take it orally, it's just destroyed by your stomach acids. You don't get very much. And it goes into the liver portal, which finishes the job, that it's really not useful. Hargrove and Maxon showed that it gets picked up with chylomicrons and goes into the lymphatic system like other fats. It's treated by your body as a fat. I took to AI about this question. I wanted to do a little bit deeper dive, and I said, which is right? And AI said it's some of both, and that seems to be reasonable to me.
Yeah, yeah, absolutely. And I think that's like so much. I feel like we put this massive pressure on hormones to be perfect the second they go in a woman's body that we don't offer to any other supplement, medication, lifestyle change. We kind of accept that we know there might be a side effect. There might be, it might not be right for your body. But the minute progesterone, someone has a negative response, it's demonized and it becomes this narrative you're intolerant to it. And one of the things that I'm so frustrated with at the moment is this narrative. If you have ADHD, you are progesterone intolerant. This absolute blanket statement that, in my opinion, is nothing more than clickbait and people wanting to draw attention to their platforms. What would you say to that statement?
Oh, I say there's no such thing as progesterone intolerance. Um, there actually could be, and it's probably extremely rare, an actual allergic reaction. And one lab in the US used to actually report a sensitivity to progesterone. And I said, as an antibody, and I said, how can you do that? Antibodies form to proteins, not
Mhm.
to steroid fatty like
Mhm.
rings. That's not possible. And of course, it isn't. What was measured is progesterone attached to a carrier protein. And there were some individuals that could have a sensitivity they're making antibodies to, but this is actually really rare, and the lab doesn't even measure it anymore. For the most part, there is no such thing as progesterone intolerance. I did write a blog too. I called it Women Who Don't Like Progesterone. I got two complaints. Both of them said, no, you should have said women who hate progesterone.
And it's true. There are,
It's,
it's so emotional when there's nothing more that I see on the internet and the hormone world that really gets people going. And I want to really witness and validate that, in that when women are having this extreme emotional reaction and public response to seeing something about progesterone, of course, I understand that they've had a really negative experience that was very, very real for them. And I think the challenge is saying, when we're talking about progesterone intolerance experience, what is happening in that? What is actually going on, Carol?
so what I think is there's not much attention paid to all the places that progesterone is made and your body uses it. So we had John Lee saying, oh, your ovaries make 20 milligrams. So that's all you need. But your adrenal glands make it. Your brain makes it independently. Mast cells, uh, mast cells have the whole hormone cascade inside of them. And when estrogen is dominant, not enough progesterone, histamine is released. So progesterone is an amazing antihistamine. It prevents that release. And this is what image I have in my mind. Have you ever seen little old ladies and they always have to carry a Kleenex or a kerchief because their nose is dripping all the time? What's that? That's a histamine response,
Yeah.
and they do not have enough progesterone to manage whatever estrogen they have on board. And so I've had clients say their nose stopped running after their first dose of progesterone. It's
Amazing.
it's amazing, but we just accept this as a normal thing, and it's an active sign of not enough progesterone. So now we have this mast cell activation syndrome. And even I see the experts, they're writing about this antihistamine, that antihistamine. And yes, you can get a little relief from counteracting that histamine that is dropped, but why drop it in the first place? It's a big signal that there's a hormone imbalance and you can't fix it. So I usually say that progesterone cannot handle the histamine once it's dropped, but progesterone itself does help your body make the DAO enzyme, which is in your gut, which is supposed to deactivate histamine. The other thing, here's another thing that is involved with progesterone has to manage a balance with estrogens. And we can have normally high estrogens, like I talked about in perimenopause. We can have excessive estrogen because our liver and gut do not process it and get rid of it appropriately. We can be short on detoxifiers for estrogen, any number of things. And then, because I was doing work on breast cancer and progesterone, it's very interesting to me. I did also ask AI, why are there areas of your body that concentrate estrogens, as the breast cancer would do? Why is there such a high concentration there? So we actually have independent production of estrogen by the cells in that place. It can also grab it from the serum, but it'll make its own estrogen. And I think a classic example of that is endometriosis. Those little plaques just are little estrogen factories and creates a lot of disturbance because your body doesn't have enough progesterone to deal with that increased amount that's in your body. You're simply falling short. So methylation is needed for histamine, it's needed for estrogens, it's needed for adrenaline. And this is a big problem I see many women, and they're estimating like about 40% of the population has some impairment of methylation. And so when all these estrogens, histamine needs balancing, adrenaline needs balancing, these are functions that progesterone will help you with, but you may be stacked against your progesterone because you're not detoxing these molecules and you retain it. In the case of ADHD, I would say it's probably a bottom line thing that you simply can't get rid of all that adrenaline. Now, I just wrote a blog about how progesterone helps you manage adrenaline. So there's a couple different processes, but that's part of its function. So you put a teeny tiny bit of progesterone and you've got all these things going on because you've been so imbalanced. I think it makes the estrogen more sensitive. I think there's something with the adrenaline output because I don't think estrogen particularly gives you like those heart palpitations that adrenaline does, but that whips up really, really quickly. And so you need to have more progesterone immediately. One of the pharmacists I worked with came up with this every 15 minutes until it flips. And sometimes I really have a big problem with trying to encourage somebody to take more because they simply need it. I just met with a woman. She coached with me for a while. She just came back and said, she said, I'm in terrible shape. My father's going to have this big surgery. I don't even want to go into the other things. She looked horrible. She couldn't sleep. She was so stressed. And I said, you need more progesterone. We'll help you deal with this stress. You've got some unrelenting stress that you have to deal with. She followed up with an email. She said, I'm taking 100 milligrams of progesterone every hour. She said, I feel great. And then she said another one of her complaints was that she's experienced all this fluid retention. Again, big red flag. Progesterone antagonizes aldosterone, which when that's out of balance, you'll retain all this fluid in your body. And she goes, and my body's back to normal, just like that. And I said, that's what you're going to have to do right now to manage the kind of stressors that you have going on in your life. Maybe she can play with the scheduling a little bit, but she needs to be generous. And she said, I can hardly believe it. And that is the nature of what progesterone is supposed to do for you.
So this really highlights again for me how far behind and how basic the current model is around progesterone, because there's so many nuances here. And this is what I love about my work, and I love that the functional approach that you take, Carol, is it's what else is going on in the body. It doesn't make sense to go, well, your body can't cope with progesterone because it's producing progesterone whether you've got ovaries or not. And this is my argument in the ADHD world of saying, firstly, you're intolerant because you're ADHD. That doesn't make sense to me, because one of the things that is really well documented around ADHD women, that consistently they say, when I was pregnant, I felt great. When I was pregnant, my ADHD felt like it had gone. You see ADHD women go, oh my gosh, when I was pregnant, and you can see the joy light up. Okay, so progesterone in pregnancy, off the chart, right?
Right.
So these two statements cannot both be biologically true. It's impossible. Can't have ADHD, you have to progesterone intolerance because you're ADHD, but if you're pregnant and ADHD, you're generally going to feel amazing. Can't both be true.
Uh-huh. Can that be true?
What this traction that this is getting is, I think, when I hear the things you're talking about here that affect progesterone intolerance, there's I can see how physiologically we're more prone to needing a nuanced, tailored approach to progesterone rather than the bog standard 100, 200, because we're much more prone to histamine intolerance, because we have the Rolls Royce of nervous systems that pick up everything and annihilate our adrenals in the process. We're more likely to have nutrient deficiencies. We're more likely to have methylation issues. So it would make sense that ADHD, we're at higher risk of having an adverse reaction to the crappy low doses. Would you agree?
Absolutely, 100%. And I'm
Yeah.
sure those low doses are okay for some women. If you're aging gradually and you want a little progesterone, helps with wrinkles and things like that, helps your skin, and you use a little progesterone, you feel it's great. Good. You don't
Yeah.
need very much. But there are women, and I would say particularly look at the history, even go so far back as how was the pregnancy of your mom when she had you? Because I firmly believe that there is a spot in the whole um, length of the normal progesterone amounts during pregnancy. In the US, it's like 50 nanograms per deciliter, all the way up to 200. This is the textbook, and now some labs even show higher levels of progesterone in the third trimester. I believe that if you're hovering around 50, you're at danger for a miscarriage, and if you do have a pregnancy, you're going to have at those low levels, you're going to be more nauseous. If you're nauseous throughout your whole pregnancy, you know that you are progesterone deficient the whole time. That's estrogen causing that nausea. And I'm sort of convinced right now that we should be supplementing progesterone during pregnancy. I have a study given to me, and I can send it to you afterwards, with a fertility clinic who showed better outcomes when, even with normal amounts of progesterone, they gave a little more, and the serum levels were a little bit higher, and the whole process was easier. For example, if you have a painful birth, at birth time, you're supposed to increase the hormone relaxin to ripen the cervix. Well, what stimulates the relaxin? It's high amount of progesterone, that you have to have a very high progesterone to make enough relaxin to make that birth easier. So why wouldn't we be paying attention to this? And using extra progesterone, you avoid things like gestational diabetes. You avoid things like eclampsia. Those
Wow.
those those things are really important. And then what was very interesting about this study, because I'm always saying we can't even get to the third trimester levels with supplementing, so the sky's the limit as far as I'm concerned. But then, so I was astonished because in the study they tested the fetal serum of progesterone, and it was 6 to 7 times the mom's.
Wow.
So when you're a little bitty thing and you're male or female, you used a whole lot of progesterone. So this is one of the safest compounds you could ever run across. It's probably safer than water. And it's just astonishing. So I think we need to spend a little bit more time with making sure women have good pregnancy. So if your baby is born and the baby is colicky, what could you do with that? Put some progesterone on them. And then, ADD, ADHD. I heard somebody do a podcast, and he was saying, if you're young and you have that diagnosis, it could be a nutritional deficiency. If you're if you're older, if you're a perimenopausal woman and you get that diagnosis, it's a hormone. But I think it's hormones all the way through. You've got to make sure that that's the case. And then I want to really emphasize B6 and magnesium. B6 is the coenzyme progesterone uses. magnesium is the cofactor. And I've been reading some books. A friend of mine, I got to be friends with him from his first book on vitamin D. And he's written another one. I like it. It's called The Winter Gene. And he's talking about how we're affected by low vitamin D. And he emphasized you can't take higher levels of D without enough magnesium. That also needs magnesium. And progesterone too. If you do need to use generous doses, you don't want to create another deficiency of magnesium or B6. Those things should be also used as you're using progesterone.
Again, comes to another factor around, how nourished are women. I see women come into clinic who don't eat properly, highly stressed, drink, there's no supplementation there. And it's like, well, the body needs this nourishment to be able to process the hormones so that you can get that effect. So it is so important that women are having these conversations. And I think one of the challenging thing is once women then get empowered with this information, they're then like, well, where do I go? Now that I have this knowledge, who is, because I don't know a prescriber, certainly in the UK, that would work with someone who is in severe suicidal ideation with progesterone because they'd be
Mhm.
frightened to, because there's just, that fear of kickback, which then leaves women in this position of going, what do I do about this? Is that something you come across?
All the time. all the time. And it's kind of worsened in the US, and I think you've had this for a long time. In conventional medicine, there's like an upper limit for progesterone. It happens to be 200 milligrams in the US. Why is that? When the prometrium, which is the same as utrogestin in the UK, when it was approved, they were able to demonstrate that 200 milligrams protected the endometrium. I would submit there are probably women that that's not enough for, even though they got the approval. So in the conventional medicine mind, pretty much they're sticking to the uterus use of progesterone is the only thing there is, and this is enough for you, and it isn't. I'd also like to point out that during the follicular phase, as you put up your chart, progesterone was there and it measures in US units 1,000 times more than the estrogen units because they're in two different scales, nanograms per deciliter and picograms. So the number you get for progesterone, you should multiply 1,000 before you compare it to what's going on with your estrogen. And that's so abundant, and it's really hugely abundant in the follicular phase, and we often ignore it. That comes from the adrenals, comes from the ovaries too, actually, but it's steady state, it's there all the time. And one of the biggest causes of hysterectomy actually is heavy bleeding, and it's so easy to fix. That follicular phase, the progesterone is not adequate to keep that estrogen stimulation in check. They should be balanced together, and you don't get abnormally high levels of tissue in your endometrium. And then corresponding to all that, what happens if you don't have an ovulation and you don't have enough to shed, it can actually keep building up, building up. So the secret for heavy bleeding is to make sure you have enough progesterone all month long in the follicular phase too. And I think something like 700,000 hysterectomies are done in the US yearly. And the majority of those hysterectomies are for heavy bleeding.
It's
Uh,
barbaric. In my opinion, it's barbaric. We see women
yes.
time and again in clinic who come in and say, I've been told I have to have a hysterectomy. I can't think of a case that we've had where we haven't been able to get that woman having normal periods with vaginal progesterone.
Mhm.
Genuinely, I'm not saying there aren't situations where women need a hysterectomy, but that is what we see. And they're angry. They understand, like, you were going to whip my uterus out, and this is what I needed, which I suppose brings me a little bit onto, this, because all of this for me just highlights how limited the use of progesterone is in day-to-day frontline practice, unless you happen to stumble across you or the work that we do, that by chance. So another narrative, when women go really fired up and they're like, I'm ready to have this conversation with my prescriber, and they say, please, I want a higher dose of progesterone.
And it's pre-recorded. Lindsay Bergson and David Brownstein are hosting like a webinar, and it's everything breast cancer. So I don't know what the other speakers are saying, but they invited me to do a section on progesterone. First 20 minutes I got already, and then they said, no, we want an hour. And so I was really able to dig pretty deeply in this. And progesterone has so many qualities. It dampens excess aromatase. It's an aromatase inhibitor. So you have to say estrogen equals growth. And I'm not going to say it's necessarily breast cancer, because you can have fibrotic breasts and breasts with lumps. That's also stimulated by estrogen. It doesn't have to be a cancer. And so without enough progesterone to balance that, to do the aromatase inhibition, to put a little block on the estrogen production, which I mentioned, and in the breast, you're going to have some independent extra estrogen forming when this is abnormal and you don't have the check of progesterone. Another thing that it does is, I don't know if you've heard of mTOR.
No.
This is big in the aging fields, and they discovered this mTOR pathway, mammalian something of rapamycin, mammalian. I'm forgetting what it stands for. mTOR equals growth, and progesterone is an mTOR inhibitor. They discovered in a bacteria on Easter Island this compound. They call it rapamycin. So in anti-aging fields, you take a small dose of rapamycin every week to dampen down your mTOR. But why do you need that? This is very expensive. And you have progesterone available relatively cheap, according to what rapamycin talk is about. But because of that actual discovery, this whole field of interest got developed, which I think is really lovely. It also modifies like estrogen, how it's metabolized, because estrone can go to estrone sulfate, and from estrone sulfate goes over to estradiol. It can help manage that sulfatase enzyme, so you don't go excessively in the stronger estrogen realm. So there's so many anti-inflammatory. Cancer equals inflammation, and progesterone is a strong anti-inflammatory agent. And then it tends to stimulate the p53 gene, which stimulates autophagy, that the cells abnormal cells will start breaking down and your body getting rid of it. So there's so many ways that progesterone intertwines in this whole breast cancer thing and is a good thing. However, I would be really afraid, as I'm afraid when there are fibroids, even if you go in that low dose part and start blowing up some things without enough progesterone, you could have a negative effect. And I really want to speak about fibroids, because it's an indicator of high estrogen effect. The fibroids grow, the endometrium grows at the same time. They're all under the stimulation of estrogen. A fibroid would also indicate not enough iodine. So this is a problem. And women, I was reading how common fibroids were. It was astonishingly common. And often there's heavy bleeding involved, because that stimulation that's growing the fibroids also does the endometrium. So there's that heavier bleeding that can provoke the hysterectomy in the first place. If they become larger and larger, it causes pain because it's impinging on nerves and stuff. So when there's a fibroid, I'm really careful. You've got to give lots and lots of progesterone and never play with these small doses because the fibroids could actually grow. And you have to have plenty of iodine and then maybe some enzymes to help break them down. But so that's where with breast cancer issues, and that's why I prepared the slide I did. I'm really afraid of the low dose realm there that I think it goes all the way up to maybe 200 milligrams that are so-called safe for for keeping the endometrium quiet. So in some women, I don't think it's enough. And particularly if you have symptoms of progesterone deficiency, and they include all kinds of things. You can have nerve pain. I didn't mention that progesterone is made by nervous system tissue and Schwann cells, so progesterone, pregnenolone, are made there and used there. So we can't measure that any way. And I had an occasion. I was at a conference, and I went to hear the morning speaker. And later we had a happy hour kind of thing, and I saw him sitting alone. So I went over there to chat him up, and he told me that he couldn't feel his feet while he was lecturing and was afraid that he'd fall, very much afraid. So I gave him progesterone. No, no matter. And he comes back and he goes, I said, rub this on your feet. And he comes back, he said, what have you done to me? I can feel my feet. And so progesterone not only is made by those cells, it has a pretty rapid effect that in minutes it changed how his nerves were working. It's pretty exciting.
So I just feel like my go-to in my house for anything, for anyone, because we're not talking, and I know we're specifically talking about women's health here, but it's a human hormone. And based on your teachings, my husband now has progesterone, and it's been an absolute game changer in terms of his sleep quality, his restless legs, his ADHD. It's been amazing. And that support with children. And so just to finish off on the breast cancer bit, I believe everything that is said there is body identical progesterone does not cause breast cancer. In fact, it's protective of breast health in the right doses.
Right. And I'd just like to mention there's no way you should tolerate fibrotic breast disease and lumps. That means you don't have enough progesterone. You can put progesterone cream directly on your breasts if you want, but not necessary. And you should have iodine too. And that should go away. And that was my first experience with progesterone. I had fibrocystic breast disease, and when I turned 40, I was reading how progesterone is helpful for these little wrinkles around your eyes. So I started putting progesterone on my face. And 4 months later, I noticed my breasts had softened, and the biggest lump was left, but it was smaller, demonstratingly smaller. And then I happened to speak to a physician and he suggested adding iodine. So completely gone now for many decades.
That is
So
just amazing.
nobody should tolerate any kind of breast irregularity because it's already strong signals that your hormone balance is off. I would wonder how many women diagnosed with ADHD also have painful breasts when they cycle. I would say there's
Yeah.
probably a strong correlation.
Yeah, there are. It's really common because we see that strong correlation with PMT, PMDD, much more prevalent in the ADHD world, right? Which
Mhm.
one of the things that we look at around that is proper progesterone dosing for that woman. And so I guess the final myth that I really wanted us to explore today was it's a new one on me, but it started doing the rounds that we shouldn't be taking oral progesterone because the allopregnenolone that it produces when it's broken down is too heavy and sedating for the brain.
Okay, and maybe so. So when I worked at Women's International Pharmacy and we were doing those oral capsules, it was years before we put a warning sticker for dizziness or drowsiness. There were so few incidences of this at the time. I also saw a study about that time that it was 10 women. 9 had no problem with the oral progesterone. One was dizzy, drowsy, brain foggy kind of thing. And they said it was the conversion to allopregnanolone, which could be as sedating as barbiturates, which is pretty strong. And so we would suggest smaller doses, alternative dosage forms, like try it vaginally. Actually, to get to allopregnanolone, you need the enzyme 5-alpha reductase, and there's a lot of that enzyme in your skin too. So you could have it actually happen from creams.
Hmm.
If you are that woman. So I regret to say it took me like 30 years to figure this out. When I said to myself, finally, I said, if it's the allopregnanolone, why is there excessive amounts in some women and not in all women, right? And they have these effects, and I consider it a barrier to adequate progesterone therapy. And so there we go again, did a deep dive on AI. And I just asked, like, how do you metabolize allopregnanolone in the body? How does the body do it? And it's sulfation and glucuronidation. And I go, oh, this explained an incident I had. So for the first time in my whole entire life, I took 250 milligrams of progesterone in the morning, and this happened to me, the grogginess. And I go, well, I knew what it was right away. And I was had a trainer coming over. I said, okay, I've got to exercise, but we got to be really careful. I'm so dizzy. And when he left, I ate 4 eggs. And it just disappeared. So later, when I did that deep dive and said sulfation and glucuronidation, I go, those eggs flipped me.
Yeah.
And now I recommend if any of my clients are experiencing that, to use extra sulfur groups, or use calcium D-glucarate for the glucuronidation, the sulforaphane, NAC, glutathione should all work for the sulfation. And eggs work for sure because they're loaded with sulfur. And I just had a client, she was experiencing that. And I said, you have to have something with sulfur. And she had another supplement that contains a sulfur, but I wasn't familiar with it. So she took it, and she said it disappeared in seconds. So why don't I think it points out to we do have a deficiency in our detox pathways if this is occurring to you. So deal with it. It's a big problem anyway. So
And actually, that, and correct me if I'm wrong, the aloe isn't dangerous. It's just not, some women just go, I don't like it. And this is what I find fascinating about this myth, that you've got a woman in front of you who doesn't sleep, right? And I think if a woman's not sleeping, you can't change anything. Okay. Like to me, that sleep is like priority. Because so if you have one in front, you say, oh, we're not going to give you the progesterone because the allopregnanolone will sedate you so you sleep. What are you going to give her? A sleeping tablet that doesn't
yeah,
give you true sleep? Like, what's the intention around this narrative? Like, oh, it's going to give you a heaviness. Well, good, I'm going to sleep. Like I don't understand. There's no danger attached with the aloe, right?
no. It sits on the GABA receptor. Progesterone doesn't. It has to convert to aloe to actually produce that calmness and sedation in some cases. But, too much is too much. And then you look at what's going on metabolically in that particular individual. I think it's a really good documentation how everybody is a little bit different. Okay, so what do they want to give you instead? They want to give you a benzo. Benzo sits benzo sit at the GABA receptor. I was kind of thrilled to see that there's like 40 docking places on the GABA receptor, which I didn't know before. And they don't, aloe does have a different place than the benzos, and GABA has a different place, and magnesium even has a different place. So all of these
Wow.
things do work on the GABA receptor. But you're right. Why would you choose a drug when you can manage this naturally and realize what your body needs? It needs the progesterone to make the aloe to produce the calmness.
Carol, you're freaking amazing. I honestly,
Just,
I could talk to you all day. I just want to download all the knowledge and experience that you have into my brain. Thank you so much for being here today. You can check out Carol's work. She's got some amazing resources on your website, Wellness by Design. Is that
oh, you
right?
have to do the Wellness by Design project. Have to have
Perfect.
all of it. Or you can use my name, Carol Petersen, with Petersen has all E's.
Amazing. Carol, thank you so much for being here today.
Oh, I'm so pleased and thank you, Adele, for inviting me.